Hi, folks. Thanks for joining me for this second portion of my discussion of narcolepsy on Hope in the Pipeline. So, where did I leave off? We were talking about cataplexy, the episodes of sudden loss of muscle tone associated with type 1 narcolepsy. So, what causes the strange episodes of cataplexy? Well, during normal sleep, when we enter the stage of dreaming, we are literally paralyzed by the loss of muscle tone in the skeletal muscles of our body. This loss of muscle tone produces a floppy paralysis and prevents us from getting into a real safety situation where we can act out the content of our dreams while we are asleep and as a result harm ourselves or others. There is actually a separate sleep disorder where this acting out a dream behavior occurs without there necessarily being any excessive daytime sleepiness. But that's a whole podcast topic for another day. Remember last podcast I stated that in narcolepsy, due to the lack of orexin stabilizing the sleep-wake barrier or switch, sleep leaks into wakefulness and wakefulness leaks into sleep? Well, cataplexy is the result of the leaking of the muscle paralysis that protects us, which we normally experience during rapid eye movement or dream sleep, into our wakefulness while we are fully conscious and aware. Research indicates that in healthy, unaffected individuals, experiencing strong emotions may lead to very momentary muscle weakness in normal people. For example, when we refer to someone as feeling weak in the knees from laughter. But in non-narcoleptics, or most of us, the brain chemical hypocretin prevents that loss of muscle tone from being anything more than a momentary, slight, barely noticeable event. Another symptom of narcolepsy that some people experience is called sleep-related hallucinations. Once again, this experience is attributable to dream sleep leaking into wakefulness and wakefulness into sleep. People with narcolepsy can experience frequently a form of dreamlike hallucinations at the onset of sleep or when waking up from sleep. And these experiences can be vivid and frightening and are usually very short-lived, lasting only a couple of minutes, although most people describe the experience as having felt like it lasted much longer. Another example of sleep-wake barrier leakage or sleep-wake switch instability is called sleep paralysis. This happens when someone wakes up from sleep mentally, but not physically. So while awake, during a sleep paralysis episode, you can't move, and you may float in and out of snippets of a dream. You can still breathe and move your eyes, but you can't talk or even lift a finger. Now, almost everybody has experienced an episode of sleep paralysis at some point during their life, for example, when abruptly awakened from a dream by a noise. But that is much different from the problem of experiencing these paralysis episodes quite regularly. There are a few other symptoms of narcolepsy I'd like to mention. These include an experience called automatic behavior. During the daytime, during normal waking hours, people with narcolepsy can be in a microsleep lasting a few seconds, but they can continue to move parts of their body, like their hands, and they may engage in activity that they were doing prior to the onset of the microsleep, for example, typing or writing. People with narcolepsy can also experience amnesia for recall of the activity or conversation that was taking place right before they experienced a microsleep or a sleep attack, resulting in a full nap. Some patients will suddenly wake up from a sleep attack and blurt out a few words or a phrase unrelated to what is currently happening around them and then not recall doing it. I now want to turn my attention to how the diagnosis of narcolepsy is established. An astute healthcare professional should refer you to an American Academy of Sleep Medicine accredited sleep center for evaluation of a complaint of persistent daytime sleepiness for an in-depth analysis. Complicated cases of hypersomnolence or narcolepsy should consider getting a consult at the Stanford Narcolepsy Center or at the Mayo Clinic in Rochester, Minnesota. The components of a good sleep evaluation include, number one, getting your comprehensive sleep and medical history over the course of your lifetime. You'll also likely fill out questionnaires such as the Epworth Sleepiness Scale, which uses short questions to measure your degree of sleepiness and how likely it is that you would fall asleep in certain times and situations, such as sitting down after lunch or reading a book. Number two, keeping a sleep diary. You may be asked to write down your sleep pattern for a couple of weeks. This allows your sleep professional to compare how your sleep pattern may relate to how alert and awake you feel. You might be asked to wear a device on your wrist called an actigraph, which measures periods of activity and rest, along with documenting how and when you sleep over the course of several days. Number 3, undergo a nighttime sleep study, also known as polysomnography, which means mini sleep measurements. This test measures your sleep stage brain waves, heartbeat and breathing, oxygen, leg muscle activity, eye movements, and chin muscle tone, and is used to document how quickly you fall asleep, how well you stay asleep, how quickly you enter certain sleep stages, how quickly you enter into sleep itself at the beginning of the night, what else might be bothering your sleep quality, what different sleep stages you do actually go into, and how quickly you start dreaming, and how long you can remain asleep if undisturbed. You should be allowed to sleep for at least 8 to 9 hours on a nighttime sleep test in order to properly diagnose narcolepsy. The nighttime test is generally followed by a daytime test called the MSLT, or Multiple Sleep Latency Test. This test measures how long it takes you to fall asleep given a quiet environment and the opportunity to sleep every 2 hours throughout the day. People who have narcolepsy fall asleep very quickly on these naps, often within 1 to 2 minutes, and often enter into rapid eye movement or dream sleep a lot more often and much more quickly than people with narcolepsy. Sometimes we use another daytime alertness test called the MWT, or Maintenance of Wakefulness Test, which measures the ability to remain awake when sitting still in a dark, quiet environment, again every 2 hours during the day. Number 5. Finally, I liked to obtain genetic testing on all my suspected narcolepsy patients when I was in practice, specifically looking for the HLA-DQB1-0602 genetic marker. Having 2 copies of HLA-DQB1-0602 gives the patient a 7 to 25 times increased risk of developing narcolepsy. There are other genetic markers for narcolepsy, such as HLA-DR2 and HLA-DQW1. 100% of Japanese narcoleptics are positive for these 2 other markers. The genetic tests are not perfect, however. In fact, about 30% of patients with narcolepsy are negative for the genetic marker DQB1-0602 in the U.S., and interestingly, about 15% of people without narcolepsy are also positive for this marker, confirming that the genetic susceptibility to develop narcolepsy is not the only factor that contributes to its onset. We are certainly aware that there are environmental, hormonal, and immunological triggers for the onset of narcolepsy, which I discussed during the last podcast. Furthermore, multiple other HLA-DQB1 genetic variants also exist, and some of these variants actually provide some protection against developing narcolepsy. Nevertheless, the results of genetic testing are highly useful information when trying to confirm a diagnosis of narcolepsy. A complicated, detailed process which I always told my patients is based on obtaining information from multiple sources to establish stronger and stronger levels of diagnostic certainty. It is possible to determine more definitively if someone has type 1 with cataplexy versus type 2 narcolepsy by performing a lumbar puncture or spinal tap and obtaining cerebrospinal fluid and sending it off for testing for orexin A and hypocretin 1 levels to one of the few labs in the U.S. that performs that type of analysis, such as the Mayo Clinic lab in Rochester, Minnesota. The test checks to see if the hypocretin orexin level is less than 110 picograms per milliliter, whereas the level in a normal person is always greater than 200. However, there are people who test in the gray zone of 111 to 199. So how are they to be classified? And there are certain confounders of the results, such as the presence of clinical depression, which can alter hypocretin levels. Finally, I think it's important to mention that individuals of African American ethnicity who have either type of narcolepsy have been found to experience the onset of their sleepiness symptoms earlier in life, have lower hypocretin levels, but paradoxically, actually have cataplexy less often. Clearly, more research is needed to figure out the reason for these genetic differences in symptom presentation and to optimize treatment for each different subtype and different ethnicities. Now I'm going to switch gears a little bit and talk about the impact of narcolepsy on someone's quality of life. The presence of narcolepsy often causes severe disruptions to interpersonal, social, and occupational functioning. For an adult with narcolepsy, attempting to work or attend college brings some difficult challenges. The bouts of daytime sleepiness can make it harder to concentrate and perform on tests or complete projects. Classmates or coworkers who don't understand often view such symptoms of narcolepsy as being laziness. But living with narcolepsy doesn't mean you can't succeed at work or in school. I've taken care of many successful patients with narcolepsy, ranging from therapists to bank examiners to actively practicing dentists. The symptoms can be successfully managed, though, certainly requiring some discipline, flexibility in daytime routines that allow some naps, good sleep hygiene at night, and attending regular visits with your treating physician to keep medications optimized. It's important to know that narcolepsy is recognized under the Americans with Disability Act. Under this law, your employer must allow reasonable accommodations, like letting you adjust your schedule or take brief naps to manage your narcolepsy symptoms. Academic institutions must offer similar accommodations, such as an adjusted class schedule, extended test taking time, tutoring, etc. Basically, adjusting their programs to ensure the same access to higher education as everyone else. The Americans with Disability Act only protects someone with narcolepsy or any other disability if the employer knows about the medical condition. So don't wait until after you're hired or after you have a problem with performance at work to decide to tell your employer about your condition. It's a good idea to push through your anxiety and have a candid talk with your employer, your supervisor, and perhaps at some point even with your coworkers whom you think may need to know about your condition. Disappointingly, however, the Social Security Administration does not routinely recognize narcolepsy as a medical condition eligible for disability benefits. So, if someone with narcolepsy ever wants to press their fully justifiable case that narcolepsy prevents their full time employment, they would need to complete the Social Security Administration's residual functional capacity assessment and ideally hire a lawyer who specializes in filing SSA appeals. If you meet with your boss or employer or your academic institution about your narcolepsy, it would be good to implement the following tips to help you prepare. Number one, request the meeting with a formal letter that was reviewed by a lawyer with Americans with Disability expertise. Number two, bring basic informational materials about narcolepsy to educate. Number three, have your doctor provide an explanatory and confirmatory letter about your condition. Number four, decide in advance and lay out in writing exactly what accommodations you want to request to help you perform better. Some common requests that employees with narcolepsy may make include scheduled nap breaks during the day in a designated private room, a later start time in case you need to take breaks during your commute or to ensure safe driving or you have trouble waking up some morning. It could include shifts being scheduled for when you're most alert or the option to work on a flexible schedule, break times that meet your needs, whether that's longer ones or shorter ones or more frequent ones. The option to break up repetitive, monotonous tasks throughout the day to help you stay alert, including utilizing a standing desk, and the option to stand rather than sit during longer meetings or presentations may be helpful. Scheduled walks at various times during the day to help with your energy and alertness levels. Have work instructions provided to you both verbally and in writing so you don't miss anything when you're trying to actively listen but yet experience a microsleep. Permission to record meetings so you can watch and listen later when you're functioning well. Provide a workspace with bright natural sunlight or full spectrum lighting. Finally, bear in mind that not all requests for accommodations are reasonable for every job circumstance. For example, it'd be pretty hard for a trucking company to let you continue driving, since people with narcolepsy have a vastly greater risk for motor vehicle accidents. Unfortunately, reality is having narcolepsy can limit some job options. If you enjoyed this podcast, please share it with a friend. And as always, thanks for watching Hope in the Pipeline. We'll see you again next time when we continue with part 3 of this series on hypersomnolence disorders.